Hello there, my name is Nivian Sukirthan. I'm a recently graduated final year medical student from Barts. Today we're going to be covering some topics under Met 3B, specifically under the nephrology section. We'll be going through acute kidney injury, chronic kidney disease, some of the complications of renal failure, as well as renal replacement therapy. And most of the knowledge in the slides is from the Oxford Handbook, but PassMed is also a very good source for learning as well, which I encourage you to use. In terms of learning objectives that I'd like to cover today, so within AKI, it's basically like a disease profile we'll be going through. So talking to you a bit about the definition of AKI, the various stages, some of the risk factors, the etiology behind it, how we assess someone with AKI, and its treatment. A similar thing that we'll be doing with CKD as well. And then finally, we'll be finishing the presentation with a bit on renal replacement therapy. So, AKI. AKI is a very common presentation seen in hospital, often due to things like dehydration, infection, sepsis, etc. And it's defined as a rapid reduction in kidney function over several hours to days, and it's often quantified using urea and creatinine. And there's often a malfunction in fluid balance as well as electrolytes and acid base. It often results from often results in damage to varying degrees, and the KDIGO have specified here more numerical values to define AKI. So a bit more about the KDIGO staging. So there's three main stages. You can quantify AKI either using serum creatinine or urine output. So for stage 1, we're looking for a creatinine rise of more than 26 micromoles per litre in 2 days, or an increase of 1.5 times more than the baseline. Stage 2, between 2 to 2.9 times the baseline. And stage 3, if it increases 3 times above the baseline. Or if they're if they're put onto renal replacement therapy, or their creatinine raises by 354. In terms of urine output, you can see here very similar numbers. So less than 0.5 ml per kilo per hour for more than 6 hours, then more than 12 hours, then going to less than 0.3 for more than a day, or lack of urine at all for 12 hours. So some of the risk factors for development of acute kidney injury. So the elderly, those with a previous history of kidney disease, specifically CKD, those who've got congestive cardiac failure, peripheral vascular disease, liver disease, diabetes, sepsis, certain drugs, so you've got nephrotoxic drugs, certain antibiotics, such as gentamicin, belonging to the aminoglycoside family, some more common medications like NSAIDs, ibuprofen, diclofenac, naproxen, etc., ACE inhibitors. All these are nephrotoxic drugs, so we need to take caution with these drugs and potentially stop them when we suspect someone has an AKI. One of the very most common causes of AKI is dehydration, so poor fluid intake can point towards an AKI picture. So we can think about the causes of AKI in a threefold manner. So we've got pre-renal, which is the most common, followed by intrinsic or intrarenal, which can be split up into glomerular causes, tubular causes, interstitial as well as vascular, and then post-renal. So we're thinking about the tubes basically coming down from the kidney, and we're thinking if there's any obstruction here or an obstruction in the bladder. Okay, some of the causes for pre-renal would be things like, dehydration, sepsis, hypovolemia, things like this. So pre-renal causes, as I've already mentioned, it's the most common cause. Some of the causes within that include hypoperfusion of the kidneys, renal artery stenosis, septicemia, hypovolemia, hypertension, and ACE inhibitors. Some of the intrinsic causes of AKI. So within this, you've got, as I mentioned, glomerular, tubular, interstitial, and vascular causes. So in terms of the most common here, it's the acute tubular necrosis, part of the tubular subsection. And it's, as I said, commonest of the intrinsic causes. Some other causes of tubular pathology that could result in AKI include certain nephrotoxins, such as antibiotics like gentamicin, radiocontrast, rhabdomyolysis, the breaking down of skeletal muscles, can result in myoglobinuria, which is toxic to tubules. We also have glomerular causes, so you've got things like lupus, HSP, some drugs as well, and then you've got all the causes of primary glomerulonephritis as well, things like IgA nephropathy, MCGN, mesangiocapillary glomerulonephritis, SLE, all those things. And also post-strep and glomerulonephritis as well. Interstitial causes, so a key thing to highlight here is tumor lysis syndrome. Often happens when patients are on chemotherapy, and there's a lot of breakdown of the tumor cells, and that can often cause a increase in urea. So it's often prevented by giving medications like allopurinol pre-chemo. Also, some other drugs can again cause interstitial problems, so NSAIDs, PPIs like omeprazole, lansoprazole, and certain antibiotics. And finally, under the vascular section, we're thinking about vasculitides, basically, and a few thromboemboli. And finally, post-renal cause of AKI, we're thinking about obstruction, really. So if you're thinking about the tubes, it could be a luminal, so within the hole. So that could be due to stones or calculi, clots, a mural cause, so within the wall itself. So this could be, anywhere really below the kidneys. So ureter, bladder, prostate gland, and then finally extrinsic compression from things like retroperitoneal fibrosis, for instance. Right, so how we assess a patient with AKI, we're really going to pay attention to the circulation part of the A to E approach. So we're thinking about pulse, BP, cap refill time, peripheral cyanosis, JVP, heart sound. So we're thinking about, and urine output. So we're really thinking about their fluid status. In terms of blood tests you want to be thinking about, mainly it's urea and electrolytes, because you're worried about potassium excretion not being sufficient in AKI, and that can cause a buildup of potassium, which can be very harmful. Right, so history, what we're trying to look for. So think about the risk factors I've already mentioned, diabetes, CKD, peripheral vascular disease, congestive cardiac failure. Think about those under the past medical history. Think about previous renal disease, as I've mentioned, CKD. Make sure to have a good appreciation of the patient's fluid balance. Are they drinking enough? Are they having enough intake? Have they been starved? Things like nil by mouth precautions taken pre-surgery. Things to consider there. Chemotherapy here, I've mentioned, when we're thinking about tumor lysis syndrome, an intrinsic cause of AKI. Any other systemic conditions, so SLE, and any other systems that you think could be involved. So if someone's got a renal as well as a respiratory picture, we're going to be thinking about pulmonary renal syndrome. The clue is often hemoptysis, and the causes of pulmonary renal syndrome include GPA and eGPA, so GPA formerly known as Wegener's, eGPA formerly known as Churg-Strauss, microscopic polyangiitis, and good posture syndrome, anti-GBM. And also we've got to think about other GI symptoms. Fine. So, examination. So we've got to do a full exam, probably, focusing more on the A2E, but also fluid status, cardiac exam, etc. Some things that you may identify on examination which may help you towards your journey towards an AKI diagnosis. So if you've got something like a palpable bladder, you may be thinking of a obstruction, a post-renal cause. If you've got palpable kidneys, could it be due to polycystic kidney disease, in which case it would be an intrinsic cause of an AKI. Any pelvic masses, again, causing a post-renal obstruction, like an extrinsic picture. Renal bruits, so things like renal artery stenosis, and rashes, again pointing towards SLE and other rheumatological pathologies. Bedside investigations. So we always start with the basics. You've taken your history, you examine the patient, and then do your bedside tests. So simple one, urine dip. So we're going to have a look for infection, specifically leukocytes and nitrites. Have a look for glomerular disease, presence of hematuria, proteinuria. Bear in mind, it may not be macroscopic hematuria, it may just be microscopic, but again, the urine dip will elucidate this. Have a look also on the microscopy if you send off the urine for things like casts, crystals, and cells. You can also do a culture and also Bence-Jones protein. It's a bit specialized, but something to be aware of. Often helps in pointing towards a diagnosis of myeloma. Blood tests. So full blood count, again to check for infections. Usinase, I've mentioned earlier, pay very close attention to the potassium. Liver function tests as well. Clotting function, have a look at baseline inflammatory markers, check the acid-base status using an ABG. We know that the kidneys are heavily involved in maintaining acid-base homeostasis. Blood cultures if you're worried about infection. And then some more specialized tests if you're thinking about some of those immune conditions would be some of the tests listed here. So protein electrophoresis, complement, which would be low in things like SLE, autoantibodies, so ANCA, that's present in GPA, ANA, a very common autoantibody, not specific for SLE, but some people with SLE can have ANA, anti-nuclear antibody, anti-GBM for good pastures disease, and anti-streptolysin O titer for strep. Imaging. So once we've done, your blood tests, you may want to refer for some more for imaging to have a look at the basic anatomy of the kidneys. So doing an ultrasound can give us an idea whether there's any obstruction, any hydronephrosis, of which there are varying grades. We can have a look if there's any cysts. If there's small shrunken kidneys, perhaps pointing towards CKD. If you notice that someone has not passed urine at all, so therefore anuria, you may want to be considering an obstructive cause. So in elderly men, a lot of the times it's often due to prostate issues, and we need to do imaging for that, mainly ultrasound and also CT-KUB to elucidate any calculi present. With things like calculi, in terms of the history, it can also be quite helpful. Like a loin to groin pain is often what patients complain of. And of course there are varying types of stones, which you should be aware of. The reason why I mentioned no contrast is because we know contrast can damage the kidneys. So therefore we're trying to avoid that. So that's why you do a non-contrast CT-KUB. Chest X-ray, useful if you're worried about things like pulmonary edema, again if there's fluid overload. And finally, when you're looking at these images and you're trying to differentiate between it being a more acute versus a chronic picture. Often in things like CKD, the imaging would often show small shrunken kidneys, whereas it's not really the case for acute. But the definitive sign of CKD is blood tests and such as creatinine, and also having a look at the GFR. So, referring to the nephrology team. So you should assess the patient first, have a think whether you think it's pre-renal, intrinsic renal, or post-renal, and make sure to get very unstable conditions, things like hyperkalemia, pulmonary edema. Make sure you've started some kind of management plan. But there are some instances where it's always best to ask advice, best to refer. So things like hyperkalemia in an oligoanuric patient. If you're still having evidence of hyperkalemia or fluid overload despite adequate medical treatment, and signs of increased urea. And there are some instances where you ought to consider referral, but not as urgently as the 3 here listed above. And always tell the nephrology team in an S-bar manner, tell them the situation, so you know who the patient is, what they're presented with, their background, past medical history, things like diabetes, peripheral vascular disease, heart failure, your assessment of the patient, pretty much an A2E, and any of the examinations that you've done, blood tests, and then recommendation, what you think ought to be done. And so probably you want an assessment from the nephrology team, or something that their team would recommend to you, so that you can do something in the meantime before they arrive. So it's important that you get your points across, especially in a condition such as AKI. So management. Really, we're trying to think about how we can prevent further damage to the kidneys and maintain a good volume status. So assess their volume status. Again, very simple things under the heading of C, circulation in the A2E. So we're thinking about urine output, so put in a catheter to assess this. Think about the JVP, the turgor of the skin, have a look at their OBS. If they're fluid overloaded, think some of the signs may be an increased JVP, 4 centimeters above the sternal angle. If you can hear crepitations in the lung fields, if you can feel for edema in the legs or the sacrum, and an S3 gallop when auscultating the heart. Aim to match input with output, really, with the fluids. You don't want to underdo it or overdo it. Account also for things like insensible losses, which is far more important when someone is pyrexial. They're febrile, so therefore they're going to be losing a lot of moisture through sweat. So make sure to account for this, and think about the inputs and outputs. Inputs, food and drink, or IV fluids that's running through a drip, and think about output. So urine, stool, any other drains, post-surgery, vomit, things like this. I also already mentioned that we're thinking about preventing any further kidney damage. So making sure to stop nephrotoxic drugs, as I've listed there, and to monitor them. And it may well be that it's out of your comfort zone within the ward environment, so you may need to send them to ICU, HDU, for more intense monitoring. Fine. So treating the underlying cause. So if we just quickly brainstorm it according to the various causes. So we're thinking about pre-renal, address volume depletion. I've told you that pre-renal is the most common cause. Often patients are dehydrated, their volume deplete, so often bang in some fluids. If you're thinking about sepsis, think about the sepsis 6, 3 in and 3 out. So 3 in, oxygen, IV fluids, IV antibiotics. Out, lactate, blood cultures, and urine via the catheter. And you may need to refer to ICU, as I've mentioned already. Intrinsic renal, often it can get quite complex, so getting some advice from the nephrology team. who may consider dialysis. So dialysis is considered really for the following indications. So if the patient has got pulmonary edema, hyperkalemia, severe metabolic acidosis, symptoms of high urea, so encephalopathies and pericarditis, and certain drugs which go by the acronym BLAST, so barbiturates, lithium, alcohol, salicylates, and theophylline. Post-renal cause, we're really thinking about obstruction, aren't we? So catheterizing them can be a good start. Imaging, CTK-UB, checking for calculi, renal ultrasound, checking for hydronephrosis, all these things that we've mentioned earlier. And here we really want to be discussing with perhaps a urology team to think about nephrostomy tube insertions or retrograde stents being inserted to relieve obstruction. So, the complications of AKI. I'll go through in more detail number 1 and 2, but just to be aware of these two. So, uremia. I told you that the major symptoms that we often experience are often encephalopathy or pericarditis. So, it would be good to contact the nephrology team and treat them symptomatically. In terms of patients who are acidotic, they may also need dialysis. Also, sodium bicarbonate is also a base, therefore it can counteract the acid nature of the blood. But again, it's not something that you as an F1 are going to be doing. Again, it's good liaison with nephrology as well as the critical care team. Right, so hyperkalemia. First of all, thinking about what the ECG may show. So the classic are these tall tented T waves. This is what I mean here. That's classic exam questioning. Some other signs you may see, non-visible P waves, increased PR interval, broad QRS complexes, and patient may even go into VF. So, managing it. This is a number to get into your head. 10 mils, 10% calcium gluconate or carbonate. The reason why we give calcium carbonate or gluconate, it doesn't, I want to emphasize this, it doesn't reduce potassium levels. Okay? All it's doing is it's trying to stabilize the myocardium. Okay, from fatal arrhythmias. So that's the logic behind giving calcium carbonate or gluconate. Once you've done that, and obviously the indication for this would be a potassium level above 6.5 or a potassium level above 5.5 with ECG changes. After that, we can think about giving a co-infusion of insulin and glucose. Insulin helps to drive potassium into cells, therefore reduce the potassium levels in the blood, and glucose obviously to prevent hypoglycemia from the insulin. Salbutamol again works in a similar way to insulin, again trying to push that potassium into the cells, as does bicarb. But as I said, all these measures, these three here, are to reduce potassium levels. The first urgent thing, if you're worried about the patient, you see ECG changes, the potassium level is really high, you need to give them calcium carbonate gluconate first. And then all of these are temporary. Inevitably, you will lower the potassium via normal renal clearance once you sort out the underlying etiology, whether that be a post-renal obstruction being sorted out via catheter, or pre-renal failure, hyperperfusion of the kidneys due to dehydration, sorting that out with 0.9% normal saline fluid. Fine. Right, so thinking about pulmonary edema now, so you would potentially have covered this under the CR module, so I'm just going to talk briefly about this before I move on. So sit the patient upright. They're going to be less breathless if they're sitting upright. Obviously lying down, if you think about your heart failures patients, there's some of these symptoms they experience, things like PND, orthopnea. Symptoms often are worse when lying down. Okay, so we're going to sit them upright, give them high flow oxygen, monitor the ECG, and we're going to give them diamorphine. It's a venous dilator. Furosemide, big doses here to get rid of that excess fluid, and nitrate spray. All of this algorithm can be found in the Oxford Handbook under the emergency section. Right. Fine. Final few things now on AKI and the differences between hemodialysis and hemofiltration. I will come on to both of these terms during the renal replacement therapy section of this presentation, but just to introduce it briefly, hemodialysis is very good in clearing solutes. It can do that quite quickly. But there's quite a few fluid shifts. Patients can often become hypotensive, so their BP can drop quite massively. So they need to be relatively hemodynamically stable in order to tolerate such a physiological demand that is enforced by hemodialysis. And therefore, if they are likely to be hemodynamically stable, chances are they're going to be on the ward. Whereas with hemofiltration, this is done continuously on ICU because the patients are less hemodynamically stable, and therefore the hemofiltration mechanism provides less shifts in the patient's blood pressure. However, it is a bit slower than hemodialysis to clear off those solutes. Right, so now how we prevent AKI. Major thing really is, again, thinking about those three headings: pre-renal, intra-renal, post-renal. So pre-renal, making sure they're well hydrated, keep drinking during the day. If we're thinking about intrinsic renal, thinking about nephrotoxic drugs. So there are certain drugs that can be quite dangerous, especially if someone is dehydrated. So diuretics, ACE inhibitors, metformin and NSAIDs. So you may need to withhold some of these drugs when patients are ill. So ACE inhibitors can often present with hyperkalemia themselves, whether that be related to AKI or not. But if the patient is hypotensive, i.e. the ACE inhibitor dosing is way too much, and it's not being cleared quick enough, then you may need to stop it. Metformin, you need to stop it if the GFR drops below 30. There is a risk of lactic acidosis. NSAIDs, as I'm sure you're aware, are nephrotoxic drugs. Some antibiotics, some antivirals, and some antifungals, like amphotericin. Think also about opiates in renal failure, because they can accumulate, so make sure you have the reversal agent, naloxone, to hand. And finally, IV contrast can also be toxic to the kidneys, so making sure they're well hydrated pre and post procedure that requires contrast with a litre of 0.9% sodium chloride. Right, so that's it pretty much for AKI. I hope that's been useful and it's made sense. So now I'm going to move on to the second bit of this presentation, chronic kidney disease. And I will also be covering complications of renal failure as well within this section. So, definition once again. So, chronic kidney disease is a very common pathology in the community, and it's defined as an impaired renal function for more than 3 months, and can be based on abnormal structure, function, so anatomy, or a GFR below 60. With or without evidence of kidney damage. There's 5 stages to it, with varying degrees in the GFR. Patients often really only display symptoms after stage 4, so when the GFR is below 30. And this is quite problematic because chronic kidney disease has quite a high mortality and morbidity rate. So the onset of CKD symptoms can be very insidious and just creep up on the patient without their knowledge. Some of the common causes of chronic kidney disease include diabetes, hypertension, glomerulonephritis, infections such as pyelonephritis, and reflux nephropathy, hydronephrosis and things. Right, so stages of chronic kidney disease. So stage 1 to 5, as I mentioned earlier. So stage 1 is not too bad. You're fine, really. Stage 1 and 2, really, you're okay. So stage 1, normal kidney function, 90, greater than or equal to 90. Stage 2, between 60 and 90. Stage 3 is split up into 2 here. So first one 45 to 59, and the next one 30 to 44. Stage 4, this is when patients start to get symptoms. So here the GFR is between 15 to 29, and then end stage renal failure, or stage 5, is when the GFR is below 15. So who would we want to screen for CKD? So these are some of the risk factors or some of the pathologies that are associated with CKD. So diabetes, high blood pressure, cardiovascular disease, structural renal disease, recurrent urinary tract infections, and those who've had childhood history of vesicoureteric reflux, systemic disorders such as lupus, family history of end-stage renal failure or any other hereditary diseases, things like autosomal dominant polycystic kidney disease, and if you found hematuria or proteinuria on a dipstick. So, history and examination. So first things first, we want to try and find out what the cause may be. So thinking about the past medical history, some of the risk factors, think about family history, any other drugs they may be on that may be nephrotoxic. Think about their current status as well. So, have they got too much urea? That's not being excreted by the kidneys. Some other symptoms, which are maybe a bit more specific. Women may experience amenorrhea and men impotence. As I said, symptoms can often be insidious and often really only develop post stage 4. You may also notice a reduced urine output, so less than 0.5 mils per kilo per hour. Dyspnea, so maybe due to fluid overload, as well as ankle swelling. So on examination, you may well find pallor, and that can be due to anemia, a uremic tinge to the skin, so like a yellowish tinge, purpura, excoriation, which is a scratching of the skin due to pruritus generated by high urea, high blood pressure, and cardiomegaly. On examination, you may also find large palpable kidneys, and you may want to consider maybe it's due to polycystic kidney disease. You may find high potassium, high urea, and that can result in things like encephalopathy, arrhythmias, seizures, and coma. So a bit of a more focused examination now when we're thinking about the renal system. So if patients are on things like dialysis, we may want to have a look for AV fistulae in the arms. Do they have any signs of previous transplant surgery? So I'll come on to it later, but those who have just had transplant often are on steroids. So therefore, that can cause symptoms of things like bruising. Skin malignancy is also common in those who've had renal transplant. Again, have a look at the face for pallor, as I mentioned, anemia, yellow tinge urea. Certain medications, apart from steroids given post-transplant, include calcineurin inhibitors, such as cyclosporin. Classically, they cause gum hypertrophy, as well as hirsutism, which is male pattern growth of hair, really. A Cushingoid appearance, again, due to steroid use. Have a look at the neck if you're thinking about any lines that have been inserted. The abdomen, look for a peritoneal dialysis catheter, a Tenkov catheter. And can you have a look for a hockey stick scar, which is the scar used for renal transplant. You may even be able to feel a mass there. And elsewhere, just systems review, really. But if you think about diabetes, check for retinopathy in the eyes. Do a diabetic foot exam, having a look for neuropathy. Is there evidence of cardiovascular disease, any bruits? Is there evidence of peripheral vascular disease? Maybe do an ABPI, an ankle brachial pressure index measurement. So investigations to carry out, very similar to AKI really. So full blood count, have a look for any signs of anemia, just basic inflammatory markers, use and ease, having a look at the urea, creatinine, etc. Glucose, if you're thinking about diabetes. Have a think about hyperparathyroidism. Often in patients with a very well developed CKD, they often have high phosphate, and therefore to counteract this, the parathyroid glands go into overdrive, and they start to increase their PTH concentrations. And then over time, secondary hyperparathyroidism can lead to tertiary hyperparathyroidism. You may also find increased ALP and eventual bone breakdown. Always dip the urine. May need to send it off for microscopy culture and sensitivities. And a very good investigation to think about will be the albumin to creatinine ratio, urine specifically. Imaging. So ultrasound, once again, to think about the anatomy of the kidneys. Again, I've mentioned how you differentiate between acute problems and chronic problems. Chronic kidneys disease often gives very small shrunken kidneys. There are causes of chronic kidney disease which can cause enlargement of the kidneys, and they are often infiltrative conditions. So things like amyloid, myeloma, but also things like polycystic kidney disease, diabetes, and as well as HIV. Other scans that we can think about, DMSA, MAG3, they can assess renal function specifically. And finally, you may want to think about biopsy. Right, so how we'd monitor someone's renal function if we're thinking they may have CKD. So thinking about baseline measurements, creatinine, GFR, because kidneys will often deteriorate, don't tend to produce much symptoms, as I said, until post-stage 4, and can be very non-specific, causing a rapid decline in renal function. There can be very many causes of insult really to the kidneys. So it can be infection, dehydration, hypertension, metabolic disturbances, perhaps in calcium, and obstruction, as well as nephrotoxins. As you can see, a lot of these overlap with AKI as well. And then one thing to be very acutely aware of is a falling GFR is a very big risk factor for cardiovascular disease, which is the chief cause of death in CKD. Right, so referring to the renal team. So there are again very stringent criteria here. So we're referring to renal team if CKD stage 3 or above. So this is when the GFR is below 60 or more. So you may notice moderate proteinuria, unless it's due to diabetes and it's already been treated, often with ACE inhibitors. Proteinuria along with hematuria, a falling GFR of more than 5 mils per minute per 1.73 meters squared in a year, or more than 10 mils per minute over 5 years. Poorly controlled hypertension despite all your antihypertensive drugs that you follow on the algorithm. If you've got, suspected genetic causes of chronic kidney disease and suspected renovascular problems like renal artery stenosis. And definitely if you don't have any of these, but the patient is CKD stage 4 above, you need to refer very urgently. So investigations carried out. So why we're doing that? We're trying to identify and treat any reversible causes of CKD. If we're thinking about obstruction, when we do something like an ultrasound, kidney or CTKUB, we'll elucidate that. Thinking about nephrotoxic drugs some electrolyte abnormalities, and also thinking about overall picture in cardiovascular disease or diabetes. So, complications and how we're going to reduce the risk of progression. So, blood pressure, easy, ACE inhibitors or angiotensin receptor blockers. Renal bone disease, we can give phosphate binders for that, and vitamin D supplements. Cardiovascular modification, things like aspirin and statins, because we know cardiovascular disease is the primary cause of death in patients with CKD, and addressing diet, so restricting foods with a lot of potassium and phosphate. Symptom control, so anemia can often be due to lack of EPO. So we may need to give recombinant form of that. May need to give standard conventional replacement for iron, B12 or folate. Make sure to exclude causes of a falling red cell, a falling hemoglobin, such as infection, hemolysis or blood loss. And always ask for help from the hematology team. Acidosis, we sort of touched on it earlier and under AKI, but sodium bicarbonate. But be careful because the sodium load can often precipitate hypertension. Edema, loop diuretics really, so things that are used in heart failure and stuff. Things like furosemide is the most common, metolazone as well. And restricting sodium and fluids. And finally, restless legs and cramps. It's not very common, but it has been reported. So apparently a low ferritin can worsen symptoms, so being aware of that. Clonazepam, benzodiazepine and gabapentin can often help with restless legs. And quinine, the anti-malarial drug, has also been studied in its use to help with these cramps. And make sure, always consider when it comes to kidneys, are there any drugs that we don't need to be using in the patient, whether we can stop them for a period of time because they're likely to be nephrotoxic and can often worsen the picture of CKD. So I've just summarised here really what I've spoken about. So complications of AKI on the left here. Acidosis, treat that with bicarb. Urea, symptoms like encephalopathy, pericarditis, treating that with dialysis. Pulmonary edema, high flow oxygen, diamorphine, furosemide. Hyperkalemia, thinking about calcium gluconate, insulin plus glucose or salbutamol for that. And we've talked about CKD as well. Anemia, thinking about iron, B12, folate, as well as EPO. Renal osteodystrophy, thinking about vitamin D supplements, phosphate binders, restricting phosphate in the diet. And restless legs and cramps, which we just touched on, things like clonazepam, gabapentin, and quinine sulfate. Fine, so the final bit of my presentation now, renal replacement therapy. Okay. So the three main treatment protocols for chronic kidney disease include these three. It's probably the last stage we get to really to treating chronic kidney disease. The most definitive one, as you're probably aware, is kidney transplant, but this is becoming increasingly difficult to get hold of. So hemodialysis, first one. So blood is taken from the patient, it's passed over this membrane against the dialysate, which is flowing in the opposite direction, and via diffusion the molecules move from a high concentration to low concentration. Larger solutes don't clear as well. Disequilibrium syndrome, in terms of problems associated with hemodialysis, we're thinking about disequilibrium syndrome, hypotension, and also access problems to form the fistula. So there may be a clot, stenosis. It can also be quite time consuming. It can't be done at home. Patients have to come in 3 or 4 times a week and have to stay in hospital every time for around 4 hours. So it can be quite damaging on their lifestyle. And this is quite a good way of thinking about what we're trying to remove. So sweat, so salt, water, electrolytes, acidosis and toxins. That's what we're trying to remove from the patient's bloodstream. I've just put a diagram here demonstrating what we've just talked about. Hemofiltration, not so much here. I did mention it earlier under the AKI section, but really hemofiltration is often for those who are a bit less hemodynamically stable. Often they're on ITU, HDU, but there's less fluid shifts associated with it compared to hemodialysis, and that's why it's preferred in those who are hemodynamically unstable. Moving on to peritoneal dialysis now. So peritoneal dialysis is often preferred by patients because they can stay at home really and don't have to come into hospital as commonly. So the peritoneum acts as a semi-permeable membrane, again exchanging those solutes, etc. And it happens via ultrafiltration. The problems associated with it include peritonitis, so it's a tunneled insertion that we're using to put the PD catheter in, so there can often be an infection there, and the peritoneum can often lose its function of the membrane function. So just a diagram here to demonstrate what we've talked about. So just a diagram here showing the catheter being inserted into the peritoneum and exchanging those waste products from the bloodstream, which is shown here. So we're getting rid of all this stuff, this nasty stuff, potassium, urea, excess water, overload, creatinine and any acids, and we're trying to form like an equilibrium in the right hand side of this picture here with these amino acids and these acid base buffers. So we're trying to create an equilibrium between peritoneum as well as bloodstream. Okay. Right, so some of the complications of renal replacement therapy. So the main one I've already mentioned, cardiovascular disease is the major cause of death. Protein calorie malnutrition is most common in hemodialysis. Renal bone disease can often be just related to CKD as well. Infection, amyloid deposits can cause carpal tunnel syndrome, arthralgia, as well as fractures, and malignancy is also very common and can be common in dialysis patients. Can be related also to end-stage renal failure, often in patients taking a lot of analgesia. Urothelial tumours can be quite common. Right, and final few slides now on renal transplantation. So this is, the last stage really we can for patients. It's the treatment for end-stage renal failure, but it is a very major surgery with immunosuppression and very many complications. There are some absolute contraindications. So if the patient has a raging infection at the time, cancer, and if they've got any other severe comorbidities, disabilities. In terms of grafts, we've got 3 types. The best is living donor, the worst is DCD. So DCD is donation after cardiac death, so they don't meet the criteria for brainstem death, but it's just when their cardiac output has ceased. There is a problem with delayed graft function because warm ischemic time is increased here. Donation after brainstem death, they do meet the criteria for brainstem death, but they remain on cardiorespiratory support for the retrieval of organs, so therefore there's a reduced risk of delayed graft function, which is seen in DCD. And finally, living donor, which you often see in the news and things, where it can be related or unrelated person giving an organ to the patient, and there's a lot of forms that need to be signed, a few assessments that need to be carried out before the donor is given permission to give the organ to the recipient. Immunosuppression. So we're thinking really about induction and maintenance. So to induce someone onto the immunosuppression, 2 main drugs. I wouldn't worry too much about their names, just be aware of them really. But basiliximab, which is an anti-interleukin 2 receptor antibody, and also alemtuzumab, and they provide really quite good immunosuppression and offer a steroid-free regimen, because we know steroids can cause numerous side effects: osteoporosis, hyperglycemia, hypertension, infection, Cushing's disease, Cushing's syndrome, bruising of the skin, thinning of the skin. So there's a vast array of problems associated with steroid use. So if we can prevent long-term use of steroids, all the better. And as I said, side effect of steroids can often be hyperglycemia, so that's why it's often not preferred in diabetics. Excuse me. And then for maintenance, we're thinking about triple therapy. So calcineurin inhibitors, cyclosporine. Side effects include hirsutism and gum hypertrophy. Tacrolimus, again another calcineurin inhibitor, often associated with NODAT, new onset diabetes after transplant. Also steroids, methylprednisolone is a common one used, and then finally antimetabolites, things like azathioprine. Always make sure to check TPMT activity, thiopurine methyltransferase activity in those who are about to take azathioprine, and also check mycophenolate. Mycophenolate is another option in the antimetabolite group. All right, final slide now. So, some of the complications of transplants. So you've got the most common one, cardiovascular death. I've already banged on about that quite a few times. Surgical complications, so bleeding, thrombosis, infection, leaks, hernia at the site of incision. The delayed graft function, which is more of a problem in DCD. There may well be rejection of the organ. You've got acute versus chronic. Within acute, you've got humoral, which is antibody mediated, and cellular, which is the more common type. Drug toxicity, which I've already mentioned, but NODAT associated with tacrolimus, and hirsutism gum hypertrophy associated with cyclosporin. Agranulocytosis and hepatitis associated with the antimetabolites. So always when you're counselling patients, make sure to tell them if you've got symptoms of an infection, sore throat, make sure to see your GP, because they are at risk of very low white cell count. Infection due to immunosuppression, it's pretty self-explanatory really. So that poses them to far greater risk of opportunistic infections such as Candida albicans, herpes, pneumocystis jirovecii, pneumonia, and cytomegalovirus. And finally, malignancy. So things like squamous cell carcinoma on the skin and some viral associated cancers are more common in those on immunosuppression. As I mentioned, some viral-associated cancers, so EBV, Epstein-Barr virus, and post-transplant lymphoproliferative disorder as well. Women often have cervical smears monitored, again for that worry about malignancy transformation. So that's pretty much it. Thanks very much for listening. So today, just to summarize, we've covered AKI. We've thought about we've thought about definition, the causes of AKI, how to assess a patient with AKI, suspected AKI, and how to treat them, as well as its complications. We've done pretty much the same thing for CKD, and finally, we've talked about the complications of CKD and how to potentially manage each of those, and finally, renal replacement therapy, namely hemodialysis, bit on hemofiltration, peritoneal dialysis, as well as renal transplantation. Thank you very much for listening, and the very best of luck for your exams.